All right. So let's start. We'll give it about 20 seconds for people to sign in. Good evening and welcome to tonight's Men's Health webinar with Dr. McBride. Tonight we will cover the signs, symptoms, and treatment options of erectile dysfunction and stress urinary incontinence. You're welcome to ask questions anytime during the presentation. Simply navigate to the toolbar that comes up if you tap your mobile device or move the mouse on your laptop or PC. Find the chat button, click on it, type your question in, and hit submit. And Dr. McBride will answer those questions at the conclusion of his presentation. Without further delay, I want to introduce Dr. McBride.
Good evening, everyone. Thank you for joining us. We'll go ahead and get started. Thank you, Mike, for the introduction. And this is just a brief little summary of who I am and my background. So I'm obviously a urologist, but I'm also a fellowship-trained men's health specialist. So essentially, my entire practice is taking care of men and their unique issues regarding erectile dysfunction, basically this talk tonight, but also prosthetic surgery, microsurgery, infertility, et cetera, et cetera. So excited to share this information with you all. We try to do these a few times a year just to sort of educate everyone about some of these various men's health topics and issues. As you may have heard about erectile dysfunction, there's a lot of people out there trying to offer various treatments. And so I think it's important to know what it is and what are some of the more mainstream research-based treatment options that are available. So before we get into those, let's first discuss what is erectile dysfunction. What is ED? So ED is essentially the inability to achieve or maintain an erection that is firm enough for sexual intercourse. And that's defined by the patient telling me there's a problem. That's also defined by the partner. And a lot of times couples will come in and we'll chat about this as a group. But I think what still is surprising to most people is how common ED actually is. And about half of men over age 40 have some degree of erectile dysfunction, which is approximately 39 to 40 million men just in the United States alone. So this picture shows you a diagram of kind of what happens when an erection takes place. If you look over on the left of your screen, you'll see a penis in cross section here that is not erect. Okay, and so there's basically, I don't know if you can see my pointer on the screen moving, but there's these two hollow spaces inside the penis called the corpora cavernosa, and they are essentially mostly empty and do not have much blood flow in them under normal circumstances, right? So day-to-day activities. And so as you see below the penis is what we call flaccid or not erect. But with sexual stimulation, you're aroused with your partner, etc., the body opens up the blood vessels that go into these natural hollow spaces, and sort of like a floodgate, blood rushes into those chambers. The penis grows and stretches into an erection, as you can see here at the bottom of the screen. So when this process does not work properly, not enough blood flow into the penis, or the penile tissue, the spongy tissue inside the penis is not able to trap the blood flow, difficulty with an erection or ED can occur. So what causes ED? And this graph shows you a breakdown of sort of the general categories of what can cause erectile dysfunction. And by far the most common is going to be vascular disease, heart disease, disease of the blood flow system. As you can imagine, if you don't have adequate blood flow into the penis, that's going to be an issue. Diabetes is the second most common and definitely kind of plays into the vascular etiology. There's a lot of crossover between the two conditions, how they kind of go together. But, medications, pelvic surgery, hormone issues, other rare and unusual causes, trauma, or things like that can also lead to erectile dysfunction. But remember, regardless of the cause, ED can have a very significant negative impact on your quality of life. It's not just about having an erection or being sexually active. It's all about how you view yourself, how you carry yourself in your relationship with partners, and things like that. So we're going to go into some of these categories a bit more in depth. And the first one I want to briefly touch on is diabetes. As we mentioned, this is a very common cause of erectile dysfunction. And approximately 15 million men in the United States do have diabetes. And in terms of erectile function, these men are more common. It's more common for them to have erectile dysfunction than the average patient or the average male. And their ED symptoms are less responsive to some of the simpler treatments for erectile dysfunction, such as the oral therapies like pills. We'll briefly touch on this later, but shockwave therapy, et cetera, they tend to be less responsive. And their symptoms are more severe and require some of the more potent therapies that we'll talk about in our presentation. But occasionally I'll have a patient come in with erectile dysfunction and I'll diagnose the diabetes. And that's sort of the presenting symptom of their disease is erectile dysfunction. So it's very important to be aware of that. Next, we'll talk about heart disease. Again, already kind of briefly touched on this, but the real important fact I want everyone to take away from this talk tonight is the connection between heart disease and erectile dysfunction has to do with not only the blood flow into the penis, but also blood flow to your heart, blood flow to your brain, to other important parts of your body. And because the blood vessels that carry blood flow into the penis are significantly smaller in diameter than the blood vessels that go to your head, through your neck, or the ones that are giving blood flow to your heart, the blood vessels carrying blood flow into the penis may be affected earlier by plaque buildup or other diseases that affect the blood vessel system or the cardiovascular system. And so erectile dysfunction can function a little bit what we call as the canary in the coal mine, or an early warning sign. And so we know from research studies that men may present with erectile dysfunction and then 2, 3, or 5 years later, then have symptoms of a heart attack or stroke or other manifestations of underlying cardiovascular disease. And a lot of times guys will come to me and already have these other conditions diagnosed, and they've maybe had a stent put in their heart or something done with a blood vessel in their neck, et cetera. But that's one thing that I'm looking for in their history, is to see, has this already been diagnosed, or is this already a known issue, or perhaps we need to work on that with that particular patient. So it's important to understand that connection just for general health prevention. Low testosterone. So, I was in clinic today, saw a fair number of men with low testosterone, and there's certainly a connection. What I tell folks is really more the connection is it's hard for many of the simpler erectile dysfunction treatments to work if you have low testosterone. So you need to make sure that testosterone is normalized to make sure that the ED therapies are working at their maximum potential. But ED, just like low testosterone, ED, both of them are very common conditions. So we talked about ED affecting about half of men over 40. Low testosterone is not quite that many men, but it's about 40% or so of men over age 45 or 50. So definitely an aging issue as men get older, but obviously it's connected to other health conditions such as obesity and diabetes, prostate disease, et cetera. And so we definitely, a lot of men come in with both issues, ED and low testosterone. Now, thankfully, there's lots of ways we can treat testosterone. I'm not going to go into an in-depth discussion of all those various treatment options. But again, just to emphasize the point that I don't really, outside of the context of maybe a really young patient under the age of 40 who has erectile dysfunction, but other than that, it's pretty rare that just treating low testosterone alone will completely solve an issue with erectile dysfunction. But it is very important to make sure that testosterone is addressed so that, like I said, the other ED treatments can be as effective as possible. Prostate cancer, we just had Prostate Cancer Awareness Month last month in September. Of course, this month is Breast Cancer Awareness Month for women. But prostate cancer, very important cancer to be aware of and screen for in men. And as we'll see here, treating prostate cancer for some of these men may lead to ED. And so in this picture we have, and we'll visit this picture later in the talk some more, but essentially you have the bladder here. And again, I'm not sure if you can see this pointer or not, but you have the bladder that stores the urine. Urine flows through the urethral tube as it passes through the prostate and then on into the urethra as urine is exiting the body. And whether you surgically remove the prostate, as we see in this picture here, where the prostate is absent because it's been surgically removed, or you radiate it. Same concept. These yellow sort of lines around the prostate represent the nerves that are sort of the thermostat or the regulator of blood flow into and out of the penis to have a normal erection. And so when you surgically traumatize those nerves, even if they're preserved, or if you radiate those nerves, there can be some residual dysfunction, and then that patient may develop erectile dysfunction. So those are just some very common causes of erectile dysfunction that we see very commonly in the office and in patients. But let's talk now about, well, how do we treat erectile dysfunction? What do we do? So the patient has it, they're having trouble, their partner's telling them something's going on. How do we treat it? And this is sort of the traditional menu of options that we have available: oral therapies, injections into the penis, vacuum erection devices, suppositories that can go into the urethra, and penile implants. I'm also going to briefly talk about some non-FDA approved, what we call experimental therapies that are being utilized and promoted in the community, and we'll briefly touch on those as well. But first and foremost, oral medications. I'm sure everyone's heard of Viagra or Cialis at this point, probably have tried it at some point along the way. They're all generic now, so they're nowhere near the cost that they used to be. But essentially, these medications, contrary to popular belief, they will not spontaneously give you an erection. You have to be aroused, you have to be with your partner, you have to be stimulated. But when you have that stimulation, when you have that arousal, these medications enhance the natural blood flow into the penis by releasing nitric oxide so that the erection may be fuller and last longer. And so for many men that try these medications, anywhere from about 70 to 80% of men will notice a positive improvement in their symptoms, but they certainly can have side effects. And if anyone has taken these, they may appreciate that fact. But obviously anything from a headache, facial flushing, blurry vision, heartburn, with a few of them unique issues like lower back pain, sinusitis or nasal congestion. And for many men, that's why they don't like to take those medications. And so that's what usually leads to some men discontinuing the use. Next, we have intracavernous injection therapy or penile injection therapy. So this is exactly as it sounds and is exactly as you can see in the picture. Basically, the patient or the partner will inject directly into the penis, into the shaft of the penis, a blend of medications that are potent vasodilators, and they will open the blood flow into the penis and create an erection. Now, injection therapy, different from the pills, will give you an erection, unrelated to sexual stimulation or activity. I actually use this in the office to help do diagnostic testing for the blood flow system of the penis with a penile duplex ultrasound study, because these medicines are strong enough that if the patient has good enough blood flow, these medicines are strong enough to get that blood flow into the penis, and it should create an erection even if the patient is not sexually aroused. So that's good from the standpoint of efficacy. And so again, a lot of men will try penile injections and report that they are successful and they have a positive result at home. But as you can imagine, injecting yourself in the penis for some men is a bit of a roadblock. But I think even more significant than that is about a third of patients will have a deep ache or pain in the penis while these medications are active, because they're so aggressively stimulating blood flow into the penis. I call it sort of like a penis migraine. And so that, and also the fact that it's a little bit inconvenient and non-spontaneous to in the moment of passion and arousal, go drop this medication, to give yourself an injection, etc. About 15 to 20% of patients will continue to use this type of treatment for more than 6 months. So even though it works in pretty well initially, pretty high fallout rate over time. Next, we have the vacuum erection device. So this is a mechanical device, as you can see, where basically the patient would put their penis inside of this tube. A vacuum is created with either a manual pump or a vacuum operated, and blood flow is drawn to the penis. Now, vacuum erection devices can be quite effective at getting blood flow in the penis while your penis is in the vacuum device. The catch is when you take the device off, it's much more difficult for the penis to maintain that blood flow. And so a lot of times to really have the maximum effect, you have to use a tight constriction band or constriction ring that you put at the base of the penis to trap the blood flow and maintain the erection. And for most patients, that's where it becomes difficult because for some people, they can be uncomfortable, cumbersome to put on. Again, you're trying to do this sort of in a moment of passion and arousal. But I do like these vacuum devices from a standpoint of penile exercise. And I may bring this phrase up again later, or if you patients that have seen me in the office have probably heard me say this, but if you don't use it, you lose it. And that is very true with erectile function and as it relates to penile length and girth. And so a vacuum erection device can be great at helping preserve penile length and girth, but it's not very satisfactory to use as a method of achieving erection for sexual activity. We also have the urethral suppository. This is a medication that much like the penile injections, the medication that's used called alprostadil is a potent vasodilator. And this medication is inserted into the urethra and it dissolves through the urethra into the vascular part of the penis to help create an erection. It's a little bit more convenient in the sense that you don't have to inject yourself. You just put this down the urethra, but that process can be uncomfortable for some men. But really the biggest issue by far and away is the fact that this medication, when you dilate the vascular tissue of the urethra, which is a separate blood supply than the main blood supply to the penis that generates an erection. When you vasodilate the urethra, it can be quite uncomfortable. And so I've had several patients want to try this and they come back and say, yeah, I tried it once and it wasn't worth it. But once in a blue moon, I will have a patient try it and like it. And if it works great, hey, it works great. But just be aware of the discomfort in the urethra with that medicine absorbing. So this is where we'll talk a little bit about some of the alternative therapies or investigative therapies. And there's really three just to at least mention. So there's low intensity extracorporeal shockwave therapy, which has been called a dozen other things: Gaines wave, dual wave, this wave, that wave. Everyone's particular spin on this to try and make it sound unique and different. There's also intracavernosal stem cell therapy, where you inject stem cells into the corpora cavernosa of the penis, as well as platelet-rich plasma therapy or injections. Certainly, the stem cell injections and the PRP are very, extremely investigational when it comes to treating erectile dysfunction. They have a well-established role in treating inflammatory conditions in the orthopedic world, knee arthritis, hip arthritis, back issues, and these therapies can work quite effectively in those areas. PRP is great for hair loss. I don't know, I may need that at some point, but when it comes to erections, there's not a great, the research is limited to animals, but even in animals, the efficacy for improving erectile function is very marginal at best. And really these therapies have a lot of cost associated with them because they're experimental. And so I would definitely caution you to think twice about that. Shockwave therapy for the right patient can be very effective. It can be a good therapy. It's been approved for use in Europe for over 5 years. And so we have a very good body of research to pull from. I do offer it in our office. And really, I implore patients to think about shockwave therapy as, the ideal patient is this is a substitute for taking Viagra Cialis. If Viagra Cialis work well and you just don't like the side effects, then shockwave therapy can be used and the patient can expect a good result from that, and hopefully not have to use the medications anymore. But unfortunately, the way it's marketed in the community and promoted, it's sort of like the end of the line Hail Mary. When nothing else has worked, let's come in and do some shockwave treatments and get things working again. And it just doesn't work that way. And again, it's experimental, a pretty decent out-of-pocket cost. And so just be mindful of that. And then the other category we have not talked about yet is penile implants. And so penile implants, I would say, are certainly the more definitive treatment option for erectile dysfunction. And in this, sort of array, you see the many decades and iterations of the penile implant, from the malleable, the 2-piece inflatable. Today we have the 3-piece inflatable, and really that's the gold standard for 2022, is a 3-piece inflatable penile implant. So how does this work? So we talked earlier about a normal erection functioning by blood flow coming into these essentially hollow spaces in the penis. And once they fill with blood flow, you have an erection. But if the blood flow system is not working properly, the implant is a pair of silicone balloons or cylinders that go into those naturally hollow spaces. And the balloons are connected to a pump that's in the scrotum. And you can see there, it sits inside the scrotum, but in front of the testicles. And so the patient or their partner, or both, however it works well with the relationship, can squeeze and release the pump. And as you squeeze and release the pump, fluid goes into the cylinders and an erection can be established. And this process, the consistency, the reliability, the fact that each and every time you want to inflate the implant, you can have an erection. The fact that the patient and the partner are in control of how long the erection lasts for, and it gives you a lot of spontaneity, is what leads to a very high satisfaction rate. Anywhere from 96 to 98% of patients and their partners would say they're very happy, very satisfied with the result of an implant. And that's really the highest satisfaction rate of any of the treatments we've discussed tonight, higher than shockwave therapy, higher than pills, etc. So this is a little video I'm going to play here. That's an animation of not a real patient, of course, but a simulated patient. So on the outside, none of the parts or pieces of the implant are visible. And you have the 2 cylinders and the pump. And as you can see, he's squeezing and releasing the pump so that fluid can go into the cylinders to create an erection. Once that erection is established, it does not go down until you push the release button to release the fluid back into the implant, into the reservoir. Once the fluid goes back into the reservoir, the erection is over. The penis goes back to the resting state, and that's the end. And so it's there ready to be used for the next time the patient and their partner want to be sexually active. So as you might have gathered so far, a penile implant does require a procedure to have it placed. That type of procedure is an outpatient, come in, go home the same day procedure with light anesthesia. For me, I do that through a small incision in the top of the scrotum, sort of near the base of the penis. And within 7 to 10 days, my patients are returning to normal routine daily activities. There's usually a little bit of lingering bruising and swelling at 7 to 10 days, but by that point in time, most of that has gotten better. At around 2 weeks, you can resume pretty much any activities you feel comfortable doing. And then around 3 weeks, 4 weeks, we'll start working with the patient and teach them how to use the pump, inflate, deflate. And if they're happy, they feel well, they've otherwise healed up well, they can be sexually active. So it's a pretty quick recovery and return to sexual function. So what are the ups and downs? We're going to talk about ups. Just to recap, I've said a lot of this already, but the highest satisfaction rate of any treatment option for erectile dysfunction, and some would say it's the single best solution for erectile dysfunction because of this high satisfaction rate. A lot of insurance plans will cover it, particularly Medicare, VA, TRICARE, etc., which is a bit of a surprise for some people, but it's true. The result is durable. So these implants mechanically will last. I tell patients on average about 10 years. A few may find theirs wear out at 8 or 9 years, or some will last 11, 12, 13 years, but what average is about 10 years. And it gives you a natural appearing penis, a natural feeling erection, and it's completely concealed, and it allows you to be spontaneous. Now, it is a procedure. It's in general, a low risk procedure, but there are things that can happen. For example, infection. So any device that's implanted in the human body is a slight risk of infection. Thankfully, with the modern 3-piece implant with antibiotic coatings, that risk is approximately 0.8 to 1%, so quite low, but not zero. As we mentioned, the device will eventually mechanically fail and have to be replaced. But any type of mechanical problem or issue does require a procedure to repair it. And this is really not a reversible thing. That it's not a if you try a pill prescription, you can take some Viagra and see how it works. And if you have terrible side effects, then you stop. With a penile implant, once you go with an implant, that's how you're going to be, and that's fine. But it's important to make sure that everyone's aware of that and that that's known going into it. And so so the risk of something going wrong is quite low. And again, very high satisfaction rate, very low complication rate is why this has become a much more popular therapy than it used to be. So to learn more about ED, I think this website here, edcure.org, is a fantastic resource to kind of rehash some of the information that we've discussed this evening. I also have on my website a lot of information about erectile dysfunction and some videos of patients of mine who've had surgery with me, and their success stories and their impact on their quality of life, and how treating erectile dysfunction has helped them in more ways than just having erections. So definitely check out edcure.org or themensmd.com. So with that, I'm going to get a quick sip of water, excuse me. All right, good to go. So we're going to switch gears completely and talk about our urinary leakage or urinary incontinence. And urinary incontinence is essentially just uncontrolled leakage of urine from the bladder. And there's really two types of incontinence. There's what we call urge incontinence, where the patient feels the need to urinate and they know they need to go to the bathroom. They're trying to get there quickly enough, and you leak before you get there. And that leakage only occurs when you feel like you need to go. What I want to focus on tonight is the other type, which is called stress incontinence. And so that is where you cough or you sneeze or you change your position, like I'm sitting and I go to stand up and all of a sudden I have a gush of urine come out. That's what we call stress incontinence. It's nowhere near as common as erectile dysfunction, but still approximately worldwide, about 500,000 men do experience this type of urinary leakage. And so that is a real number. So just like we did with erectile function, how do we normally urinate? What's the normal process? So obviously our body produces urine as a result of metabolism. Urine collects in the bladder, which is essentially a water balloon or storage bag for the urine, until you feel like you need to go. And then you say, okay, great, I'm going to go to the bathroom, let urine flow through. So that process of letting the urine flow, there's a little valve at the base of the bladder and a valve at the base of the prostate. Both of those have to open. Urine flows through the prostate and down the urethra and out body. And when you're done, all of that kind of closes down and goes back to the resting state, which is the bladder is closed off at the bottom and is back to storing urine again. So what can cause that to all go wrong? And really the most common cause of urinary leakage, that's stress incontinence or stress urinary leakage, is prostate cancer treatment, whether it's radiation therapy or surgery to remove the prostate. But other things that are less common, trauma. We see this with car accidents, motorcycle accidents, neurologic disorders, spinal cord injuries, things like that. They can also lead to this stress incontinence condition. And just like erectile dysfunction, as you can imagine, uncontrolled leakage of urine can have a profoundly negative impact on quality of life. And these patients tend to suffer from isolation, depression, image. Their relationships suffer. And so a lot of these men, particularly these men with incontinence, we tend to label them as silent sufferers. They tend to not be very talkative about their condition. They just sort of deal with it and kind of go on in their life. But there is hope. There are treatment options obviously available. So just to briefly recap, as far as the connection between prostate cancer and urinary leakage, we talked about these pictures earlier. When the prostate is removed or radiated, obviously for erections, the nerves are damaged, but as far as urine control is concerned, those valves on either side of the bladder and prostate tend to not work as well. And so the flow of urine has less control, and so urine can leak from the bladder through into the urethra, and you get that stress incontinence issue. So what can we do? What can patients do? What can I do to tell my patients to make this better? There will be called sort of short-term or what I call Band-Aid type treatments. I mean, you can drink less fluid, you can dehydrate yourself and make less urine, but obviously that's not healthy for normal kidney function. What I really encourage all my patients to do is do physical therapy. And I think of all these options on this list here on the screen, that's really the only thing that addresses the root cause. So physical therapy is great because the therapist can teach the patient how to control the muscles of the pelvic floor. And in doing so, the patient can, in many cases, gain fairly significant control over their flow of urine and reduce their quantity of leakage. Otherwise, it's just sort of like wearing a Depends or something like that to manage the urine once it leaks out. And then there's more long-term solutions. And so there's really two that we'll briefly discuss here, because stress urinary incontinence can affect women, much more commonly than men. There's a procedure called a sling. And so there's a type of sling that's designed for men that works very similar to how slings work in women. But the idea is that the sling is a mesh material that supports the urethra and provides some gentle compression and thereby resistance to preventing the flow of urine uncontrollably. So the sling system is all contained on the inside of the body. There is a good success rate. Anywhere from 94-95% of patients would say that they are happy with the result. And this is something that starts working immediately. So you have the procedure, sling goes in, as soon as you wake up, it's there working for you. And that's really, we'll talk about it later. There's always downsides to things, but you don't have to do anything. The patient doesn't have to operate it. You don't have to think about it. You just go to the bathroom when it's time to go. The other long-term option is called the artificial urinary sphincter. And so this is a device that is a bit more similar in concept to the penile implant, and really is considered the gold standard because it essentially mimics your natural sphincter system. So 24/7, when you're not urinating in normal daily activities, your natural sphincter is compressing your urethra, preventing the flow of urine out of the bottom of the prostate, and gives you control. When that system doesn't work properly, the artificial urinary sphincter is basically a little silicone cuff that does the same thing, and it squeezes the urethra all throughout the day and holds on to the urine until it's time to go to the bathroom. And so it really sort of mimics the natural system very closely. And this is a treatment option that can work for any degree of urinary leakage. Anyone who leaks 1 or 2 pads a day or 10 pads a day, the sphincter can be effective for essentially everyone. So this picture here illustrates what I was describing. You have this cuff that wraps around the urethra that compresses the urethra, and it's connected to a control pump in the scrotum and a little pressure regulating balloon. And when the patient feels the need or the desire to go to the bathroom and urinate, they squeeze the control pump and then the cuff will open. When the cuff opens, it stays open for about 60 to 90 seconds. Urine will flow through there, and then slowly that cuff will refill with fluid and then go back to compressing the urethra and giving the patient control over their flow of urine. So again, we have a little animated video here of how this device works in real time. So just like the penile implant, all the parts and pieces are on the inside of the patient, nothing's on the outside. And when the patient feels the need to go to the bathroom, they squeeze the control pump. And as you can see, that cuff opens, urine will flow. But then after that short period of time, the cuff will refill with the saline fluid, and it goes back to compressing the urethra and giving the patient control over the flow of urine. So again, this is also a outpatient come in, go home, same day procedure. It does require 2 small incisions, one below the scrotum. The other one is on the lower part of the abdominal wall. And again, typically within about a week or so, patients are resuming their normal routine daily activities. The unfortunate thing is we do have to wait about 4 weeks in most cases before we activate the cuff to start working. So patients will continue to leak urine until the 4-week time point. when the device gets activated, but once it's activated, then it's fully functional. So upsides, very high satisfaction rate with the urinary sphincter. A lot of patients would recommend this to a friend or a neighbor. It's gives really complete control over the flow of urine, so the patient can achieve that control regardless of how severe the urinary leakage might be. And there are also, I think we have a part here to talk. Yeah, here we go. Here are the downsides. So the downsides of these devices. So the sphincter device, just like the penile implant, does have the possibility of in eventuality of mechanical failure. I mean, obviously it will break down eventually. For these, I tell folks to think more of about 8 years is a typical average for mechanical durability. But unique to the urinary sphincter device is it could erode into the urethra over time. That's quite rare, but it can happen if someone's not aware of a patient having one of these. And so we have patients get a medical alert bracelet. So if they're ever really ill or in the hospital, no one tries to put a catheter in or something like that without calling a urologist first. Any implanted device has the risk of an infection. And then back to the sling, really, I think the two things that we see with that are, one, it just fails over time. And because the sling is attached to the muscles of the abdominal wall, as those muscles get a little less robust with age, the sling loosens up some, and then leakage can reoccur. And so that's the issue over time, is the sling tends to lose its effectiveness. Vice versa, right after it's put in, it can be too tight, and then the patient cannot urinate at all. And it's rare, but there are scenarios where the sling has to be released and to open that up and restore. Otherwise, it's so tight the patient cannot urinate. That's really rare with men. It's more common of an issue with females getting sling procedures, but that is something that we always have to be aware of. So I think the big thing to take away from the stress urinary incontinence part of this discussion is there's hope. There are treatment options that are available. And I think a lot of guys just isolate themselves and think that it's only happening to them. It actually happens to more men than you probably realize. And there are options. There are ways to fix that and make it better and restore the independence and the confidence to go out and lead a normal life. So again, great website here, fixincontinence.com. A lot of good information that we've covered here this evening. So you can definitely check that out and get a little bit more research and information on your own if you are interested. And with that, we've reached the end. So at this point, Mike, I think we'll open up for questions. And let's go through the questions.
Let's start with some of the pre-submitted questions. There's a question related to the connection between an enlarged prostate and erectile dysfunction. Is there one? And then, do any medications or treatments associated with an enlarged prostate lead to ED or cause worsening of it?
Yeah, great question. So, back when I was in training, I remember the textbook would talk about, men with enlarged prostate are more likely to have erectile dysfunction. Also understand that those data came from 20, 30 years ago when we really did not realize how common erectile dysfunction actually is. And my opinion now is that I think there's really no connection. I mean, I see plenty of men that have enlarged prostate and have normal erections. When half of men over age 40 have erectile dysfunction, also a very significant number of men will have age-related prostate enlargement. It's really hard to say if it's causative or not. What I can definitely say, though, definitively is there can be some side effects from medications. So certainly one category of medications that basically hormonally starves the prostate in an effort to try and get it to shrink over time. That medication can lead to sort of tinkers with your hormone levels. And so you can get decrease in your sex drive, erectile dysfunction. It's pretty rare, but some men will report some penile numbness and lack of sensitivity. The other category of medicines that we use commonly to help with urine flow in men who have prostate enlargement, the alpha blockers like Flomax, et cetera, they don't really have any, quote, ED type effects or erectile effect, but it's more when you ejaculate, the fluid does not come out. For many men, the fluid does not come out like it should, and it'll sort of go backwards into the bladder. So when you ejaculate with sex, very little to no fluid comes out, which is just a bit of a alarming, unless I tell my patients about it, but if the patient hasn't been told about it, it can be alarming and surprising. And so, but beyond that, those medications do not have any effect.
That was a question about, can a prostate biopsy damage the surrounding nerves in the area leading to erectile dysfunction?
Yeah, good question. That's actually been studied a couple times. And fortunately, today we use a lot of prostate MRI to reduce the number of biopsies. But not that long ago, 7, 8, 10 years ago, really all we had was just biopsy. And so patients would get biopsy after biopsy after biopsy. And some men would have, especially if they had like a low risk type of prostate cancer, that we were not worried enough to treat, but we were just keeping a close eye on. Some of these men would have anywhere from 6 to 10 biopsies, in their lifetime. And there were studies showing when you start getting into the 3, 4 biopsy, that many biopsies, those men do have a little bit of an increased risk for erectile dysfunction just from the trauma of the needles going in and out of the prostate. So from that study, which is really the only study I'm aware of to this date that's looked at that, but it was done quite well. I think for 1 or 2 prostate biopsies, I don't think there's any difference. But if back in the old days, we'll call it, with a higher biopsy rate, yeah, I think it did have a little bit of an effect on erectile function.
There's a question, ED related. Someone's pills are working in the morning but not at night. Any reason that could be, or recommendations for how to alter that?
So of all the ED therapies, the pills are the most sensitive to your testosterone levels. And we know for sure that our natural testosterone production is much higher in the morning time than it is at nighttime. Especially men under 40, 45, they have what's called diurnal variations. So they'll have, a testosterone level of 600, 700 in the morning, and it could be 300, 400 in the afternoon, evening time. And that difference can have a big impact on the effectiveness of an oral therapy. As most men age, that big swing of testosterone from morning to afternoon or evening tends to get to be blunted, or it's less significant. But still, nonetheless, our best testosterone production is when we're well rested in the morning. Natural testosterone production. And the ED therapies, the pills like Viagra or Cialis, they really work the best when you have normal testosterone levels. And that's been proven repetitively. You have a patient try a prescription for Viagra or Cialis, it doesn't work very well. If you check their testosterone levels, and if they have low testosterone, you treat them with testosterone, a large number of those men will retry those medications and they'll work better when the testosterone issue has been addressed.
Now, can you review the difference again between urge incontinence and stress incontinence? Maybe touch on if there are treatment options available for urge incontinence.
Sure. Urge incontinence is basically the bladder does not want to hold urine. So when you feel the urge or the need to urinate, you know it, you feel it, you start making that effort to go to the bathroom, but before you can get to a bathroom, you're already leaking urine because your bladder just will not hold the urine any longer. That's urge incontinence. You can cough all you want, you can sneeze all you want, you can lift a refrigerator and you won't leak. But urge incontinence is leaking when you feel that need to go to the bathroom. Stress is the opposite. Stress incontinence, you could be driving from here to, Denver, I guess, and have a full bladder. And you say, well, no big deal. I'll just go a little further. There's a rest stop 10 more miles down the road. I'll just keep going. And you can control, that urge. You're not leaking just because you feel like you need to go, but it's more if you cough or sneeze, or if you waited and then you go to get out of the car, and because you're changing position from sitting to standing or something like that, now all of a sudden you're getting a gush of urine. Or in severe cases of stress incontinence, the patients have no control. I mean, they just literally leak like a faucet. They just, they don't really feel an urge. Their bladder never fills up enough to actually feel full and make you have the sensation that you have to go. It just leaks because underneath the prostate, the little valve there is just, it's wide open. It's incompetent, and urine flows continuously. So hopefully that helps distinguish it a little bit better.
Oh, thank you for the distinction, that. Now, if somebody gets an implant and has any sort of complications or trouble using it after, what do you suggest they do?
That's a very broad question. Can we be a little more specific?
Well, so somebody had an implant 10 years ago and feels like the pump might be connected to a testicle. And so if something like that happens, do they contact you? How do they go about solving the issue?
Yeah, I think that's, I guess that's the root. The basic answer is really any type of issue with an implant. I mean, there's a whole host of issues that could happen, 10 years, 8 years down the road that relate to the function of the implant, more of a mechanical type issue versus, if someone just had a procedure, 2 weeks ago. But in any scenario, obviously, I would like to talk to the patient and examine them, and or at least have them explain to me what's going on. But certainly in a situation like that where it's been some years, 8, 9, 10 years, the pump feels like it's it may feel like it's fused to a testicle, but it's really there's a distinct tissue layer there. But in some men, their scrotums are kind of tight, and so the pump does sit pretty close to the testicle. But you can also put the pump in a different location. But also an implant that's at 10 years, I start wondering, when is it going to mechanically wear out? Because obviously at some point it's going to wear out as well. So yeah, obviously happy to see any patients that are having any issues with implants. You can call our office and request an appointment that way. And there's the number on the screen, or you can go to my website, themensmd.com, and be happy to see you and troubleshoot it and figure out what we need to do.
Now, can you go over maybe differences in the pills that might make one work better than another, and then go over this highest dose that you can prescribe for certain pills?
Yeah, so I really split the pills themselves into two categories. So you have the quick acting pills and the long acting. Really, it's Viagra and Levitra, or their generic names are sildenafil, vardenafil, versus the long acting, which is Cialis or tadalafil. They both function by increasing blood flow into the penis with sexual arousal and stimulation. But the Cialis is a 24-hour medication. So you take the medication at 8 o'clock in the morning and you're good at 10 o'clock at night. And I actually think it works the easiest with patients taking a low or moderate dose, 5 to 10 milligrams every day. It's always in your system. You don't have to worry about, timing when you might want to try and be intimate. It gives you the fullest spectrum of spontaneity. And because of that, it's not a quick, boom, smack you in the face. Wow, I've got this medicine in my system and I can feel it working and I know it's there. It's just sort of in the background, always working for you a bit more. It's just a little bit more subtle. Whereas the Viagra and Levitra, particularly the Viagra, most guys will feel those side effects and say, yep, there it is. All right, it kicked in. Now I've got my 3 or 4 hour window of time before it's out of my system. Some guys like that because they know when they start feeling the side effects, they know that the medication is active. Obviously, a lot of patients don't like that because they feel the side effects. So Viagra and Levitra are much more quick on, quick off. You have to take them, within about 45 minutes or an hour of anticipated sexual activity. Some men say they don't work for hours later, so everyone's a little bit different, but that's the big difference between the two. Mechanistically, they both increase nitric oxide to increase blood flow to the penis. As far as dosing, I've had some patients say they take 150 milligrams of sildenafil, which is typically the maximum dose of Viagra or sildenafil is considered to be 100 milligrams. Some people take 150 milligrams and say it might work just a little bit better, but you're kind of like on that top of that curve where a little higher dose may get you a little more effectiveness, but you're definitely going to have more side effects. I prefer, if you want to do a combination, I prefer actually a combination of Cialis or tadalafil, taking that 5 to 10 milligrams every day, and then trying the sildenafil or the vardenafil in addition to that. And you have both of those medications in your system at the same time. I think it kind of gets to the same point of really maximizing the efficacy of both oral treatments. But again, just beware of the side effects. Honestly, the only side effect I really ever, I don't want to sound cold-hearted, but the only thing that ever really worries me from a medical perspective is blood pressure. So any of these oral therapies for erectile function can lower your blood pressure a little bit. If you combine two of those therapies together, it may lower the blood pressure a bit more. I have had a couple patients where they say, look, I feel lightheaded, dizzy. I just don't think I can do that. And I agree. If you feel lightheaded or dizzy, I certainly don't want someone to fall or hurt themselves or hit their head. So that's the biggest thing you got to watch out for taking the combination like that, is it just drops your blood pressure a little too much and you feel a little lightheaded and unsteady.
Thank you. Now, are there sublingual versions of the oral medications that are available?
So not available from commercial pharmacies. And when you look at the original, the classic Pfizer brand Viagra, it was only a pill that is swallowed. Now, there's a whole nother type of pharmacy out there called a compounding pharmacy. I use compounding pharmacies quite frequently. They have custom made these alternative ways of delivering the medication. Because obviously, if you take a pill and you swallow it, it goes into your stomach and you have to absorb it. So I just had dinner before this talk. If I took a Viagra right after dinner, it would take probably triple the amount of time for it to be effective, because I'm absorbing all the food and I'm absorbing the medication. So if you swallow a pill, particularly with Viagra or Levitra, it works better on an empty stomach. Sublingual versions kind of get around that a little bit because it just absorbs right through the lining of the mouth. They can be effective. I will just caution everyone, not all compounding pharmacies are created the same. There are compounding pharmacies, and then there are like legitimate compounding pharmacies. And so they have different tiers of FDA scrutiny. And the ones at the bottom that have very little scrutiny, you could be getting a good batch, you could be getting a bad batch, and there's not really good quality control on that. Sublingual preparations from good, top tier compounding pharmacies can be effective. But you also may pay more for that too, because it's compounded and it's a custom sort of take on the medication versus the pills. Nowadays, you can get a generic Viagra Cialis for less than $1 a pill. And so the pills now are quite inexpensive.
And there's a question specifically about low T3 and causing ED. Do we know what it is, which part of testosterone that is linked to erectile dysfunction?
So T3 is thyroid hormone. So are we asking about thyroid hormone or testosterone?
Sorry, thyroid, yes.
So T3 is the active form of thyroid hormone. So our bodies will produce TSH, which is thyroid stimulating hormone. We then get T4, but our body has to convert T4 into T3, and T3 is really the most potent form of thyroid hormone. And for most organ systems, it's what's necessary for normal thyroid function. I don't have a ton of been on thyroid replacement therapy, but I do have several. And, vast majority of primary care physicians, endocrinologists will prescribe Synthroid. Synthroid's been around for decades. My mother takes Synthroid. It's a very commonly used medication. Synthroid is T4. So your body has to convert T4 to T3. We know there is a percentage of the population that just does not convert that very well. So you either have to really ramp up the dose of the T4, or you give patients a blend of T4 and T3, which is a whole different category of thyroid medications called Armour thyroid or things like that. I tend to use those because I don't want to waste people's time if they're not converting T4 to T3. Just give them the blend. But really the T3 is important. If you don't have any T3, not only do you have troubles with erections, you'll have troubles with all aspects of sexual function, but you'll have trouble with all aspects of thyroid function as well. So fatigue, lethargy, weight gain, hair loss, constipation, et cetera, et cetera. So T3 is the important hormone in the thyroid hormone pathway.
Thank you. Looks like there's no further questions at this time, so I'll put out a last call for questions. And meantime, as you get your contact information on the screen, what is the best way to get a hold of you, Dr. McBride?
Yeah, so definitely call the office. Although sometimes if you call, our schedulers are busy, but feel free to call the office. You can also request an appointment through my website, so you don't have to worry about dealing with the phones. Truth be told, I actually get an email every time someone requests an appointment, and then I forward that email to my personal nursing assistant as well as our referral coordinator so that they can work on that. So either way works well, but be happy to see anyone who has any additional questions or concerns.
I want to thank you very much for your time and all the information this evening, Dr. McBride. Any last words of wisdom to impart on the crowd?
No, just thank everybody for attending. And did we get one last minute question, Mike?
Take a look here.
I just saw something flash up.
Yep. Does hemorrhoid surgery or hernia surgery affect ED or possibly cause it?
Hemorrhoid surgery is pretty broad. I mean, certainly if someone, so if you think about all the discussion we had about the prostate, and there are the nerves and things like that that are, right behind the prostate. Well, they also are right next to the rectum. And so it's not common. I'm maybe only seen 2 or 3 patients ever. But if someone has really terrible internal hemorrhoids and they have a very aggressive, very involved hemorrhoid surgery, I mean, maybe. I mean, that's not a established cause or something that we really, like I said, ever see. But I've had a couple patients where they had pretty massive hemorrhoids and they had to have some aggressive surgery for that. And it was a question of maybe it made their erections a bit worse. Hernia surgery, not really. I mean, there's really nothing with the hernia surgery that's going to be affecting the penis and the blood flow into and out of the penis. More of what we see with hernia surgeries are issues more in the scrotum. If there's a hydrocele or something like that, swelling or something bleeding, or hematoma that goes down to the scrotum and can affect the testicles. But by and large, it's mostly in the scrotum from hernia surgery.
Looks like that's it for questions. Thank you again, Dr. McBride, for all the answers and all the information, and everyone for attending tonight's webinar. This concludes the event. Have a wonderful evening.
Thank you, Mike. Thank you, everybody.